to go?
Yep.
Allergies.
I don't hear anything. Is that?
You will hear something in just a second.
Okay. Good morning. You're listening to WNHHLP, New Haven's home for community radio. I'm Mubaraka Ibrahim, and this is Mornings with Mubaraka, your Wednesday morning voice. Welcome to Mornings with Mubaraka, and this morning we are talking with Dr. Marian Evans, and we are talking about women's health. So we have lots of really good information for you this morning, so I hope that you are listening and you are writing. We are also, so today is, we're trying something new. We're like cross technology. We're here on the radio, we're on Facebook Live. Hey, Facebook Live. So if you go to the Fit Muslima fan page, we are Facebook Live on there. If you have questions, I'll actually run over to the screen and look at the questions every so often. So hopefully you'll be able to hear us well, and if on Facebook, and you'll be able to ask questions if you need to. So I am excited because I just like talking about women, because I'm a woman, right? And I, of course, love talking about women's health with Dr. Marian Evans, who was my professor at Southern Connecticut State University. Welcome, and thank you for joining me this morning.
Good morning.
Good morning. So Dr. Marian has been an OBGYN for 10 years, also professor at Southern Connecticut State University Public Health Department for 10 years. She was the former director of health and social services in the city of Bridgeport, and she served as a physician scientist at Yale Griffin Prevention Research Center in where's Griffin?
Derby.
In Derby. So this morning we are talking about women's health and all about women's health. So first, let's talk a little bit about you. Tell me so you became a doctor. All little girls want to grow up to be a doctor, right? At some point everybody wanted to be a doctor. It's like a doctor and a ballerina, all little girls' dream. Did you know since you was a little girl that you wanted to be a doctor? And when did that kind of like, I'm going to do this come about?
Well, first I think it's really important for me to say, and I'll just do this. I was born and raised in Bridgeport. I'm Connecticut, born and raised, and so at a very young age, and I think it had to do with my family, my mother being, working in a hospital growing up and things like that. At a very young age, I think it was about 4th grade, what I remember, I said, I want to be a doctor. And when you say that among friends in school, people sort of, you hear the little giggles and things like that. But I was very serious because I felt like I knew quite a bit from, sort of the conversations we had in our house about, sort of around doctors and in the medical profession and things like that. And I saw I had a backdoor window into sort of medicine. Through my mom and her conversations, and she worked at many of the hospitals in Bridgeport growing up, and so I wanted to be a doctor. My other, I would say, not ballerina, I wanted to be an opera singer.
Okay.
Because Marian Anderson.
Marian
Anderson,
there you go.
We shared a name, and she helped me like my name.
Awesome.
By finding out sort of what it meant and who else had that name, shared that name with me, besides how I got it in my family. And so, yes, from a very young age, I wanted to be a doctor. And basically, I am one of those, as I tell in class, those AAA personalities trying to be just the A personality, where everything after that I pursued in order to get to sort of this ultimate goal of mine of being a medical professional. And so, I wanted to make sure that I got a good education. I knew education was the key. And little did I know that education sort of is the key for everything, right? And as we learned in public health now, it is the key for many things. And so just by getting an education guarantees you, hopefully, that you'll be healthier, at least a higher education. And so, as you said in my bio, I went on to undergrad in Pennsylvania. I did most of my graduate work in Pennsylvania. So undergrad was at Swarthmore College, and then I went to Penn State for medical school, Hershey campus. And then I came home and I did a residency at Bridgeport Hospital in OBGYN for 4 years. And then...
So at what point did you decide OBGYN?
Well, that's sort of a process, right? So as you go through medical school, you're thinking about all kind of things. There's some things you never learn until you get out of medical school about things. But at the time, I wanted to be able to teach women, educate women, and I've always been very good with my hands. So very technical, whether it's carpentry, I took apart irons and record players when I was little, put them back together. So I knew I was good with my hands also. And so surgery appealed to me also, but I didn't want the straight surgical life kind of thing of what women at the time had to go through to be a surgeon. So I didn't want that, but I wanted the mixture of both. And so OBGYN actually gives you the best of two worlds. You're able to sort of be a primary care doctor in women's health, and then you're also able to do surgery. And so the gynecology part of OB basically opens the door, and the OB, because C-sections that's a whole nother conversation. But C-sections are major surgery,
right.
And that's what people forget, right? They forget that the way we've made it such a commonplace incident as part of natural, they think it's part of natural childbirth to go have a C-section when it's not, right? So C-sections are still major surgery, and we have major complications from women still having C-sections, but that's a whole nother kind of topic that we can discuss.
Talk about that a little bit.
Yeah.
So when you became a doctor, what do you remember your first patient? Like when you walked in and said, "I'm Dr. Evans"?
Well, it depends on what you mean by first patient, right? So you're already sort of, playing the role in medical school when you start to shadow your clinical years kind of thing.
Okay.
And, at least back when I was going through, we had, the book years and then the clinical years. Your last 2 years were your clinical years. And so once you put on the white coat, even the short white coat, what we call it, the short white coat versus the long white coat, when you put on the short white coat and you introduce yourself, you're already sort of there playing that role. But
so there's no official day. It's just kind of like transition.
Well, it's a traditional day of putting on that coat when you're introducing yourself. But I had never thought about my first patient, sort of in medical school, and then, no, I can't say truthfully that I remember my first actual patient. Yeah.
All right.
Yeah.
Tell me what was something that surprised you when you first got into medicine that you didn't expect?
Wow. Sort of looking back in hindsight, there were lots of things that, they never teach you in school. We could just talk about OB, right? So if you talk about OB, just the difference in care, I think one of the things that most surprised me was the first time you deal with a family around death, right? Because that's going to lead into some of our top conversation around death and fetal death, and just sort of the intense emotion and how you deal with the intense emotion. And I got to a point where I just said to myself, it's got to be okay to sort of feel these things. When bad things happen, they're very bad, and when good things happen, they're very good. What could be better than having a new baby come into someone's family kind of thing? But when bad things happen, stillbirths, miscarriages, and things like that, fetal death, they're really bad and they're really touching. And so I gave myself permission to be able to cry with my patients. Right. So
I didn't expect
yeah.
that. That's actually a really good transition because one of the things that we want to talk about today, because I always like to talk about the good and the bad and talk about what we need to improve as well as what we have improved. And one of the things that is a huge concern for America and Connecticut in itself is we have a high infant mortality rate. And let's talk about that a little bit.
Okay.
So infant mortality is what is defined as infant mortality versus having a miscarriage.
Okay. So there's two different things. So let's just deal with infant mortality first. So in layman's terms, right? I like to be able to talk to people. That's why I'm a teacher now and professor in public health or assistant professor in public health. Infant mortality is basically when a newborn does not make it to their first year of life. So thinking about, a baby being born and then they don't make it till 1 year old. Okay? So we're looking at that time window, that time frame kind of thing, versus miscarriage, right, is pretty much before that baby reaches, sort of maturity to be born kind of thing. So you're looking at a different kind of window.
So is stillbirths considered infant mortality?
Stillbirths are considered infant mortality. Yes. Okay. Those numbers would be included in some of the things that we're talking about. Okay. So a stillbirth is when a baby reaches a certain number of weeks maturity and then dies before it's born, actually. And it's very sad because it's still many times a woman will elect to still have the baby sort of the natural labor and delivery way, but those stillbirths are part of this infant mortality number.
So tell us, how big of a concern is it for us?
So in the United States, let's just look at numbers and statistics, and I like to talk about numbers a different way. So on a national level, if we think about the entire United States, there are about 23,000 babies, infants, that die each year. In 2004, the number was 23,000.
Wow.
It seems like a lot if you just think of that number, but when you think about how many babies are born and everything goes okay, and then it's not that big considering the larger number of babies that do make it and then go on and do fine. So it's a much larger number of things when they go right, and we experience that much likely, but still it's a number that we should know and that we should be concerned about. So nationally, how should common people think about that, or everyday people think about that? Think about this. When we talk about infant mortality, because it's sort of a statistical term, we're talking about per every 1,000 births, okay? Okay, per every 1,000 births. So it is the number of infants that die per every 1,000. So if you think about that number that we just talked about, 23,000, there's, for every baby born, every 1,000 babies that are born fine, there's 6 that die. Okay. That's the way to translate those numbers.
Yeah.
Okay.
I get it.
So for every thousands of babies, and we are in New Haven, so we know there's lots of babies born right here in New Haven. For every 1,000 babies, 1,000 babies, 6 of them die. Okay, that's on a national level. Okay. Now here in Connecticut, right, we live in a small state. There's lots of sort of reasons why our numbers are where they are. But for a small state, there's still something that we should be thinking about, okay? And it's important that we'll talk about what those numbers are in Connecticut. Before we go on to just Connecticut numbers, I think it's important to talk about the factors, the risk factors around infant mortality. Now you understand that it's out of 1,000 births, 6 babies die on a national level. So what's going on? What are the risk factors? What are some of the things that we should be looking for? What are some of the things that contribute to that? And so I think, and from a public health perspective, one of the most important things I can say to your audience is it is important. You know, we could talk about race, we could talk about ethnicity, we could talk about income, poverty, all of those what we call social determinants of health, right? The things that sort of impact, and you'll hear in the literature about microaggressions and things like that. But the most important thing, I think, overall, that we can talk about around infant mortality and reducing infant mortality rates is a woman's health, okay? And I mean her overall woman's health, her overall health. That is the most important factor. So this is not, I'm pregnant and now I want to make sure I have a healthy pregnancy. This is way before we start thinking about getting pregnant. We call this, and you know from my class, preconception health, right? It's about the weight, maintaining a healthy weight, not doing any of the things that we know make you overall unhealthy, like alcohol, how much alcohol you drink, and tobacco, right? Whether you smoke. I was amazed that when I went to look at the sort of statistics here in Connecticut, I'm amazed that in 2016, we still have one of the indicators around infant mortality, whether a woman smokes in pregnancy. And I'm like, oh my God, are we still dealing with this?
You know, I have to say that is actually, smoking statistics is still one of the things that surprised me the most. Before we get into smoking statistics, let me just remind my listeners that you're listening to WNHHLP 103.5 FM on your radio dial and streaming live on newhavenindependent.org. I'm Mubaraka Ibrahim, and this is Mornings with Mubaraka, your Wednesday morning voice. This morning we're talking about women's health with Dr. Marian Evans, and we're talking about infant mortality and the impact of smoking. And I have to say, you know, some of the statistics, so you know, we have here in New Haven, there's an organization, Yale Care, who has done a series of surveys in low-income areas in New Haven, and every time I see one, the biggest thing, like, the obesity rate does not surprise me. Okay, we know that people are overweight. You know, what is always the most shocking to me is the amount of people who smoke. In some neighborhoods, 7 out of 10 people smoke cigarettes. Like, that's, to me, it's like astronomical. Like, we know all of the health risks to smoking. So I can see that being like a huge issue, because when we talk about smoking, and particularly smoking in low-income areas, when you talk about infant mortality, that is where the infant mortality go up in minority communities and low-income area communities. So I can see that as being a major, unfortunately, contributor to.
This deals with my public health mind. When you say what you just said about low-income communities, the first thing that comes to mind is, who are we talking about?
People of color.
People of color, absolutely. And we know one of the great things is in low-income communities, people of color are all different nationalities, right? And so when you bring people of color together and you group them, right? And that's part of my problem with these numbers and statistics and things. There are factors, right, that are not tweeted out when you just put all those numbers together, right? They're not teased out. So there are factors like, there are various people that come to form our low-income communities that come from different cultures. Meaning different cultures that have different attitudes about tobacco and about smoking.
This is true.
In order to combat that, I believe that has to, awareness and education, right? So that means that in our school systems, in our public school systems, or wherever low-income people go to school, right, that message has to be taught and reinvigorated. I think we've gone away from, we've turned away from sort of these basic messages in some of our basic education. And I can remember being in school and saying, "Oh, smoking is bad, smoking is bad, smoking is bad." Even though in the neighborhood you see the billboards would still have cigarettes and Camels and whatever else. In the 60s and 70s and 80s, it was all of that sort of media image and hype around women smoking and things like that. But I still got the message in school: smoking is bad, smoking is bad, smoking is bad. So if they're not getting that message, that basic message anymore, even in our community. So there's various levels that I think we have to attack this, that we've sort of strayed away from, that we need to go now and revisit. I don't blame schools, right? Because I believe things start in the family also. And so that message, how we get parents to understand, this is the message you need to say to your children. Smoking is bad, smoking is bad. It's bad for your overall health. It increases 10 times all cancers and everything. And then smoking in pregnancy, right? You have smaller babies. So if one of the indicators, now I say that, and when I say indicators, because that is what infant mortality rate is. It is an indicator. It indicates the health of a community, of a state, of a nation. That is why infant mortality is actually a global indicator. Many countries that look at infant mortality. So if you look at infant mortality here in the United States and how we define it, here in other low-income countries, developing countries, in the UK and other places, it is one of those indicators that we can look across all sort of nations and countries and say, how are we doing around this issue? Because we all define it the same way. So the great thing about it is that it's an indicator. The bad thing is that we as a nation, a country, we don't do as well as other countries for many reasons that we probably don't have time to go into. But it is a global indicator. So it's a global indicator, it's a community indicator, it's a state indicator. So you went back to talking about Yale Care and the survey that Yale Care had done. And so in that survey, it talked about the numbers. So let's just talk about Connecticut before we get to because New Haven County is actually one of the highest with infant mortality. For me, when I look at that number, I say, well, who, why, when, and where? What is happening, right? And when you delve into some of these numbers, and so I want to invite your not only your listening radio, but your Facebook people, to go on the Connecticut Department of Public Health website, to put in infant mortality, and they will see the registrar, the vital statistics. There's a table, and it breaks it down by ethnicity, by races, by ages, by counties, by towns. There's various tables. There's about 13 tables, and that's what I did. That was my homework last night when I wanted to talk about this. Because Connecticut overall, because we're a small state, as I said before, from 2008 to 2010, our infant mortality number was about 5.3%. That's infant deaths per every 1,000 live births, right? We did a Healthy Connecticut plan. And that's very interesting to look at, too, on the Connecticut website. We did a Healthy Connecticut plan. And in the section where it talks about sort of maternal child health, maternal infant and child health, they made goals for 2020. And they said the goal around infant mortality for Connecticut was to go from 5.3% to 4.8%. Now, many people, right, when you don't understand those numbers, you're like, well, that's not a big jump, I'm like, that's not a big jump, 5.3 to 4.8 by 2020. Of course, why couldn't we, sort of achieve that? But then you have to go into the numbers. And so the reason why I invite your listeners to go into the numbers is because when you look at this table, you will see the breakdown with ethnicity and race. And by towns all over Connecticut and other things. Table 5 specifically talks about mothers' races, mothers' ethnicity. Why is that important? Well, first of all, I have to let my pet peeves out, but because race is a social construct. I believe that we should stop using race. Okay, we know that it's made up. Okay, I believe that we should stop using it and think of other ways to make comparisons, because I believe that our numbers would be different. So I know I'm saying this and this is just me, right? We'd have to have the federal government stop using race, and all of this other thing.
Well, I think, don't we use other things other than race? We can talk about income.
Well, we can talk about income, and we're seeing a move towards more ethnicity breakdown, right? But even when you talk about ethnicity, then right, it's hard to sort of categorize people. So now we're seeing the move towards non-Hispanic. Now how that came about was is very interesting. But we are seeing a move towards ethnicity. And I just think there needs to be another way of looking at this. So I believe that income
all
might
black
be,
people shouldn't be bunched together.
Right. I believe that income might be part of it, right? I believe that if we looked at some of those social determinants of health, when we look at some of these statistics in this breakdown, by looking at income, we know what to do around that, right? Income is about distributive justice, right? It's about equity, right? I whole nother conversation, okay? But
gotta have you back.
Right. But then if we used income, we would be able to say, okay, why is it that all of the women who make whatever, right, are doing bad with infant mortality? So what is it? Is there anything particular? I would want to know, who are these people in New Haven? Is there anything particular about the women, right? It's not about sort of genetics. We know that, right? Sort of, that piece that we've seen that they did with Unnatural Cause series, where they looked at, what was her name? Kim Anderson.
Yes, that was actually what was my introduction to the fact that it was a huge concern for, I'll use the black woman, the race of black people. But the interesting thing about that for me was how it was just so intricately connected to everything else that goes on for her.
Right.
As being somebody black. So if you are not familiar with Unnatural Causes, it is a documentary series which is very, very interesting. I highly recommend it. I will post it in the links underneath the Facebook video, but it is a series that looks at income and the health and how it affects people's health. So it follows, one of the parts of the series is it follows, which I found really interesting. It went to one hospital and it followed the CEO of the hospital, a kind of like mid-level, who was obviously a white man, the mid-level employee, which was a nurse who was the head of a department, who was an African-American woman, and it also followed a janitor who was who also worked at the hospital, who was a lower level employee. And another part of the series is they looked at infant mortality, and the woman that they talked to, she was actually a lawyer, a DA in a major city, lived in a good neighborhood. She was African American. She had graduated from Columbia, top of her class, all of the things that you would think that would give her a better chance, and it didn't. And they talked about. You want to talk about why they talked about it being that? Okay. So what they spoke about was that being black in America, you already have because of microaggressions, you have a high level of cortisol in your system. And when the women get pregnant, that cortisol automatically increases for all pregnant women. But for African American women in particular, or black women, however you want to categorize the subset, because the cortisol is already high dealing with racism in America, it rises even more, making preterm births more common or more likely because of the amount of cortisol in the system. So it didn't have anything to do with not that she had a stressful job, she was well off. It's not like she wasn't eating healthy. She had all of the things that would on the outside look as if she was taking care of herself and her body, but the social structure of America basically leads to conditions that cause preterm. That was like, to me, it was like, I probably watched that, I don't know, maybe 8 years ago, and I was like,
you need to watch it again, because
I know,
because I've watched
when I saw it, I saw a clip on YouTube. I was so fascinated with this series. You can watch it clip by clip online. I spent like $100 and brought it, so I have the DVDs because I was like, this is like, wow. So that was actually also my first introduction to social determinants of health.
Okay.
And I just was like so hooked ever since.
Well, I'm sure you've had a conversation on your radio station about that. And so,
we actually haven't
yet.
You have
we
to.
have to.
We will,
yes,
for sure.
Because there's so many different perspectives, and I must say that, when I was the health director in Bridgeport, one of the things people didn't understand is they had a very narrow vision of, some people have a very narrow vision of what health is, right? And so they think that if you're not talking about, say, STDs, STIs, TB, infant mortality or sickness or some sort of disease or disability, that is what health is about. And we know from a public health perspective that it broadens it to be able to talk about these social determinants. That's why housing and income and education and all of these things make a difference in people's lives and in their overall health. Why is this all important? Because we know around infant mortality, we have better birth outcomes when a woman's overall health is good way before she ever gets pregnant, right? So then it's like with the unnatural cause theory. So then what do you do about the microaggressions, and how do you play into that? And so this comes into my conversation about microaggressions and stress, right? I don't know about you, but I never got a class when I was growing up in school about meditation, stress management.
Right.
I think we do children a disservice, people overall, their overall health, a disservice. And this is what the other countries and European countries already have in place, when we don't teach them how to deal with stress and aggression, whether it's bullying or violence or abuse and things like that, that you have to be taught these skills and tools. Not to say that it's not going to happen, but how to deal with it, right? That's the key, how to deal with
and
it.
That affects directly the health.
So if we're having stress management classes, the first time a woman takes a stress management class is in college, that's too late.
This is true.
You understand what I'm saying? And so in Bridgeport, when we had, and I know that this is ongoing now, but to be able to introduce to young children at a very, very, very young age, meditation, stress reduction, even when bad things are happening, and bad things will happen, and bad things will happen around you, how you not let that affect you, how you have some tools and skills, right? We don't talk about that. So now I'm going into this where people will go, woo, my alternative medicine piece of mine, where there's so many things, right, that go into sort of our overall health. That, okay, I'm exercising, I've talked about this in class. I got my Fitbit on, right? I'm exercising, I'm increasing my physical activity, I'm trying to eat more nutritious. I'm doing, like the woman said, she's doing all the things, she's got a good education. What do you do about stress? Because nobody had taught her as a lawyer, right, how to deal with that stress of what happens when they come up against you at work, all of those sort of taglines, tag words, that they use sort of in our society, in our environment around discrimination and racism, okay? Like, what tools are we taught? Whether it's at home or in school, from a very young age, on how to deal with that. Now, some families, right, sometimes religion comes into play, but religion deals with discrimination and racism a little bit differently. It depends on how progressive wherever your faith and your,
and it also depends on what religion.
Right, and it also depends on what religion kind of thing, right? So that's a part of it, but that's not a total 100% answer, you know. So, you know, the first time that I got called a nigger, I was in medical school. The first time somebody walked up to me and said, my friend didn't get into medical school because you're here. You took my friend's place. I was like, what the heck are you talking about? You know, I was just like, and then I had to go and process that. And I had to digest it because I had no idea what they were talking about. Quota systems and all of this stuff. I had no idea. And then when I realized sort of what had happened, or when I was crossing the street coming from the dry cleaners in medical school, you know, somebody called me a nigger out of a car. I was like, what? You know, and so how do you deal with that? How do you process that kind of thing? And don't get me wrong, I grew up in Bridgeport. So people say, oh, you grew up in Bridgeport, you're not naive. But I must say, I led pretty much I wasn't in the midst of it, right? I wasn't in the midst of it. And even when you're in the midst of it, if you're not taught the tools and the skills to deal with all the other social determinants, right? I can remember saying to my mother, why can't I go to the school up the street, one block away from where we live, the Catholic school? Why do I have to walk down and around the corner and 5 more blocks to go to school when I got a school right across the street? She said, because you can't go there. I didn't know, right? That meant because of the color of your skin, right? You know, and my mother just said something to me like, oh, you don't want to go to school there or something, you know. She just sort of, you know, you know how mothers do, right?
I want to tell you the bad news, but
you know, it took much longer for me to understand as a teenager growing up, as I continue to walk past that school and the priests and the nuns and say, well, it's all the same God that we're talking about, right? I'm sure it's not a different God. So why is it that I can't go to church there or I can't go to school there, kind of thing, right? Which made me angry, but I wasn't given the tools or the skills on where to take that anger, what to do with it, you know? And so those are some of the things that I don't think we in our society deal with or are taught that need to be taught in this overall picture of what health means, right? So when I talk about preconception health, and like we said, the woman, good weight, she's healthy, she's exercising, good nutrition, she's getting an education, she's doing all those things, checking off all of those things that she's supposed to be doing, then there's still this piece, right?
So what do we do?
But let me just say, then that makes sense when I look at the numbers in New Haven, right? Overall, when we look at New Haven County, right? Because when I went to the 2013 chart and I looked at New Haven County, it was like, okay, all right. So now I'm going back to the neighborhood community level, right? So in New Haven, when we look at, you know, the black versus white versus the race and ethnicity sort of, what did the guy from Yale say the other night? The racial, ethno, you know, breakdown kind of thing. And I was like, oh, he really combined all that stuff together. He made a word.
We get it.
I was like, oh yeah, okay, that makes it, smooths it over kind of thing. What are we talking about? In Connecticut, what you need to know is that overall, right, still, it is white women who are still having more fetal deaths.
Oh, really?
It's still more fetal deaths. But when you do the breakdown, that and when you do the breakdown in the percentages, so let me just give you your audience, an ideal of what we're talking about when we talk about percentages. So in Connecticut, overall, 45%, right? That's the overall number. And when you do the breakdown,
45% of infant mortality happened to white babies.
right?
Okay.
Or no, 45% overall, everybody, all white, everybody in 45% overall for Connecticut.
I don't. 45% of.
45%. So of fetal deaths.
Okay, of all of the fetal deaths, 45% of them.
Okay.
Okay.
So there's 45%. That's where we sort of land in national statistics, okay?
Okay.
45%. When you do the breakdown, right? Of that, let me give you an example. Okay, let me give you a number example. So let's just say if that 45% represented 200 babies,
Okay.
okay?
Mhm.
All right, in this category of infant mortality.
Mhm.
If it represented 200 babies, and then we did the racial breakdown, okay, as you'll see in some of these charts, out of those 200 babies, around 100 of them will be to white women.
Okay.
So that was about 52%.
Okay.
You understand me?
Mhm.
And so then you have 50% left, right?
Mhm.
So 100, right?
Mhm.
50%, right? So 100, and then out of that 100, which is the other 50%, you'll have a breakdown. 34% of those will be Hispanic women, and then 29% will be Black women.
Okay.
You understand what I'm
That's
saying?
in the entire state.
Right. So if we would do
So is that in the state or is that in New Haven County?
that's in the entire state.
Okay.
Yeah, not in New Haven County. And I couldn't find that breakdown, but maybe because I just couldn't find it, kind of thing. Then I'm like, well, who are these women? You know, because originally, you know, when I was before I was ever a doctor, I was always working on some teen pregnancy and things like that. So I said, are these teens? Who are these? Like, what age group is this? When you look at the age group of this, let's just use this mythical number of 200, right?
Okay.
When you look at this age group, is it teens? So just in this sort of chart that I looked at for Connecticut for 2013, from the 15 to the 17